Thank you, Senator Hawley. Senator Hawley and I share a unique perspective. There are two sets of senators who went to the same high school. Chuck Schumer and Bernie Sanders went to James Madison High School in Brooklyn, New York, and Josh and I went to Rockhurst High School in Kansas City.
Oh, wow.
Just wanted to put that on the record. Dr. Makary, I loved the opportunity to visit with you, and I know the answer to this question, but I just want to stress it again. You didn't have anything to do with the layoff of the 1,000 FDA employees that have been laid off in the last couple weeks, correct?
That's correct, Senator.
And do you know anything about the layoffs? For example, who made the decisions or what groups of people were laid off?
I do not, Senator.
You indicated that when you come into the office, you're going to do an assessment. And I suppose, based on your experience, that if you look at this going forward, you think personnel policy, including layoffs, should be done strategically rather than just kind of willy-nilly across the board randomly, correct?
I am open to ideas on making government more efficient.
Do you think willy-nilly random across the board is a good idea or not a good idea?
Look, I'm a surgeon, so, you know, I'm going to give you a surgical answer.
Yeah, okay. That's good. It is a little bit puzzling. The administration has high confidence in you. You've got this hearing right now. They expect you to be confirmed. Probably will be based on practice. So the notion that they would lay off 1,000 people before you got there is a little bit unusual. And what we're seeing in agencies and the layoffs is that it is willy-nilly random. Probationers get laid off because they can't fight back. Probationers are disproportionately veterans. I'm glad you will be a surgeon and act like a surgeon should you be confirmed. Second thing I want to ask is about user fees, and we chatted a little bit about this in the office. We agreed that despite the need for reforms at the FDA, that the FDA is sort of the gold standard. I asked you, is there another nation that does this better than us? And you said, no, there wasn't, even though, again, you've got reforms you'd like to make. Here is an issue that's pretty technical, but it's an important one. We talked about tracking adverse events after a drug or medical device is approved. And you indicated that the FDA can do a better job of identifying issues with problems that are already on the market. It's not all about approval, and then it's about post-approval tracking. There are many different user fee programs that outline the relationship between the FDA and industry. And for most of the user fee programs, except medical device user fee, FDA can use the collected user fee dollars to conduct post-marketing surveillance. But the medical device user fee program does not allow that use of the user fee dollars. Would you agree that the FDA should be able to use the user fees collected of medical devices to do post-approval surveillance?
Senator, as you know, user fees are established by Congress, and I'm more than happy to be a part of the conversation about the best use of those dollars within the agencies. I very much enjoyed our conversation, and as you know, I'm committed to an FDA that delivers more cures for Americans and meaningful treatments, healthy food for children.
But can I just ask about this? Do you think post-approval surveillance is something that's important?
I am a big believer in the idea that we should not just turn a blind eye after the FDA approves something. Right. If we do that, we get burned with 1 million lives lost from oxycodone and OxyContin without any monitoring. That's my next topic.
And I do agree with you that making that change would be on Congress's shoulders. But I do think it's odd that we don't allow the user fees to be used for post-approval surveillance on medical devices when we do in the other areas, and I'd love to work with you on that. On OxyContin, I want to just close with this one. We're seeing some improvements. 24% decline in drug overdose for the 12-month period ending in September 2024 compared to previous year. And just yesterday, the NIH released findings of an NIH-funded study researching a new pathway to address pain issues. But 87,000 Americans died overdosed in the 12-month period, so it's an improvement, but we got so much farther to go. 1 in 4 Virginians deal with chronic pain. And one of the issues you and I talked about is, can the FDA not just be in receive mode to get, you know, the applications for approvals and approved? Can the FDA even be proactive in looking and saying, how come we don't have more non-opioid-based pain management strategies? The FDA shouldn't be picking a winner among, you know, competitors, but to look at gaps and try to incentivize or encourage filling those gaps would be smart. Could you share some of your ideas for how we might encourage appropriately the development of innovative strategies to address chronic pain without using opioids?
Thank you, Senator. I do believe the FDA should not just be in receive mode, but also partner with industry and facilitate the process and ensure that the scientific review is independent at the same time without cutting any corners on the independence of that review. The opioid pain problem can also be addressed by innovation, more localized treatments, and looking at post-approval monitoring of devices.
Great. Thank you. I look forward to more discussion about this. Thanks.
Coach